بسم الله الرحمن الرحيم والصلاة والسلام على رسول الله صلى الله عليه وسلم. As we said before, we will take one case and then we will say review on this case according to the pathology present. Here our last case was this one. She's a female patient, 57 years old and presenting with vaginal bleeding, and that was her MRI. What we can see here, first we have, this is the endometrial cavity distended with a soft tissue lesion. How we know that it's not just thickened endometrium? First, if it is thickened endometrium, like hyperplasia or polyp, it will retain the normal hyperintense signal of the endometrium. But in this case, there is altered signal of the endometrium. Instead of being bright, it becomes low signal intensity or of isoechoic signal intensity. This is the first findings. The second finding is that this lesion does not preserve the zonal anatomy of the uterus. When we see here, there is no preservation of the zonal anatomy. If we put a line on the presumed the rest of the endometrial cavity, we will see that there is infiltration of the zonal anatomy. The junctional zone here is preserved, but here is indistinct and infiltrated and even reaching the outer half of the myometrium. So regarding this is not a benign lesion. Someone who, when I put this case in the exam, they said that there is distended uterine cavity. It's not distended uterine cavity, it is a soft tissue present in the uterine cavity, replacing the normal endometrium and infiltrating the anterior myometrium and the funs. And then we must do staging of the case. In order to stage the case, we have to look for myometrial invasion. If it is less than 50% of the myometrial thickness, it is 1A. If it is more than 50%, it is 1B, as in our case here. If it invades the cervical stroma, and we see that it is invasion of the cervical stroma and not the mass is protruding in the cervical canal. If the mass is just protruding in the cervical canal, then it is still stage 1. But if it infiltrates the cervical stroma, then it is stage 2. Then stage A, 3A and 3B, tumor extension to serosal invasion, MRI figo stage 2B, vaginal or parametrial invasion. Also there is bladder and rectal and mucosal invasion. If it invades the adnexal region, it is 3A. If we have metastatic lymph nodes, then it is 3C. In this case, there is metastatic lymph nodes, but I will show later on. So it will be 3C if there is metastatic lymph nodes. 3C1, pelvic lymph node involvement. 3C2, para-aortic lymph node involvement. Then MRI figo, stage 2B, if there is distant metastasis, visceral organ metastasis or lymph node metastasis beyond the pelvis and the para-aortic lymph nodes. So it's very simple, and I think these drawings is very important to keep the in mind the staging of the endometrial carcinoma. What else we can see in this case? You have to pick all the findings. The most important is the endometrial carcinoma, but what we have here also, we have this ill-defined thickening of the myometrium, and this ill-defined thickening show minute cystic changes, bright in T2, scattered within. And we have another sign that say what is this lesion, which is the thickened junctional zone. If the junctional zone is thickened more than 12 millimeter, then it is with adenomyosis. So this case have also adenomyosis. What else? Also this case has multiple well-circumscribed hypointense lesions, well-defined. This is well-defined in comparison to the ill-defined lesion seen in the low corporeal anterior wall of the uterus. So this is well-defined and low signal and homogeneous. So this is fibroids. This is another case of adenomyosis. Here you see the adenomyosis is ill-defined, and you have invagination of the endometrial glands within the junctional zone. So this is a case of adenomyosis. Some people say, why not? It is not degenerated fibroid. The degenerated fibroid, we have not so uniform bright signal spots in T2. We have bizarre shaped appearance of the degenerated fibroid. Okay? So we will talk about endometrial lesions. Now we will take about the endometrial lesions, so concentrate with these cases. If we have female patient 50 years old with perimenopausal bleeding, and this is the endometrial thickness. The endometrial thickness here is 23 millimeters, so it's very thick. In this age group, if it is perimenopausal or menopausal, we have to not more than 8 millimeter in thickness on the maximum. So this is markedly thickened endometrium. This is by transabdominal, and when we do transvaginal, the thickened endometrium is here, but here there is reserved subendometrial halo with cystic changes present. What to do next? We must put Doppler. If there is high vascularity, then you must do DNC. If it is low vascularity and the patient is not complaining so much, you can do follow-up by ultrasound. This is 3D showing the hypoechoic subendometrial halo here. So in the 3D and 4D, we can detect better the delineation of invasion if we suspect endometrial carcinoma. So thickened endometrium in premenopausal patients, don't rush to say it is carcinoma. It's most of the cases, they are hyperplasia. But we must put Doppler to see the vascularity, because if it is vascular, we fear of being there is atypical cells there, so we must do DNC. This is the normal endometrium in the normal phases. The proliferative endometrium 4 to 8 millimeter, periovulatory 6 to 10 millimeter, secretory 7 to 14 millimeter, and you must be oriented with the different appearance of endometrium in the different ultrasound phases. If it is in the menstrual cycle or early post-menstrual, which is a thin line. And this is the same thin line that we see in the pre-pubertal age group and the post-menopausal age group. And then the proliferative endometrium, 3-line sign, and then the thickened 3-line proliferative endometrium, which is more proliferated under the effect of estrogen, and then the hyperechoic luteal phase, where we see the endometrium hyperechoic with posterior enhancement due to the thick mucosa in the endometrial glands, thick secretions in the endometrial glands occurring in the secretory phase. And this is the appearance on ultrasound. This is the triple line sign in early proliferative phase, triple line sign in late proliferative phase, and this is early secretory phase, and this is late secretory phase with the normal thin line subendometrial halo. And then this is the periovulatory, where we find striated appearance. Some books say 5-line sign, but I used to say that it is striated appearance occurring in the periovulatory phase. Another case, this female was 34 years old and coming with dysfunctional uterine bleeding, and that was her CT. I don't know why they do CT for her. We must do not CT, we must do either MRI or first ultrasound examination. What we have here, first when you come from the lower part, this is the site of the cervix. The cervix is very much bulky and enlarged. But what else here? There is a cystic lesion seen within the endometrial cavity. Here, this is the cystic lesion, and this is the large enhancing cervix. No one can say that this is a normal cervix. This is not a normal cervix. It is more large than the uterus. So there is a cervical mass here, and there is a cystic lesion inside the uterine cavity, and this is the upper abdomen. It's unremarkable, there is nothing above. And here, this is the cystic lesion. What is this? It is of fluid density. The patient proved to have cervical carcinoma. We get her for second look ultrasound, but image is not available, and unfortunately the patient is pregnant. So cervical carcinoma with pregnant cystic lesion present inside. What is the teaching point here? Don't recommend CT for pelvic masses, please, except under certain situations. If you have a teratoma, or if you have sure malignant mass, for example bilateral ovarian malignant masses, and you just want for staging and metastatic workup. 36 years old female. This is this female, she has also thickened endometrium, or there is an endometrial mass rather rounded in shape, and she's bright on T2 and low in T1, and there is also infiltration of the junctional zone. Here the junctional zone is preserved, and here there is infiltration of the junctional zone, and this is the appearance of, and there is here dilated vessels in the adnexa, and also soft tissue mass lesion present in the adnexal region. And this patient was invasive molar pregnancy. So in cases of thickened endometrium in a patient in the childbearing age, the first to do HCG level. The first thing is to do HCG level to see if she's pregnant or not. So this is an invasive molar pregnancy. A female patient, 75 years old, coming with postmenopausal bleeding. Again, did you pick the finding? Here, again similar to our first case, there is a hypoechoic soft tissue mass lesion present inside. It may be polyp or endometrial carcinoma. We could not say. The polyp in MRI is hypo-intense. So this is early endometrial carcinoma, although I think that the junctional zone here also is a little bit infiltrated. 64 years old female. Again, note here the hypoechoic, hypointense lesion. The uterus is retroverted, and there is a hypointense mass present inside. And this mass on post-contrast, it does not take enhancement. This lesion here, and there is a rim of endometrium surrounding it, and it proved to be endometrial polyp. Another case, 80 years old female, CT was done also. And here, what we can see here, the endometrium on CT is hypointense, but if we found that the endometrium is so much thickened in that age, so we should think of endometrial carcinoma also. This is markedly thickened endometrium here, thickened hypodense endometrium here. So we should think of endometrial carcinoma even on CT. Another case, female patient with postmenopausal bleeding. She's 60 years old. Here we have a large mass distending the cervical canal, but if you search about its origin, it is coming from above, from the endometrial cavity. It shows cystic changes, and in the post-contrast, it shows heterogeneous enhancement, but still the pedicle is coming from above, from the endometrium. So to me, I think it is a benign looking, either from the signal of this lesion, it looks like endometrial polyp, large pedunculated endometrial polyp projecting through the cervix. How to differentiate? It is not the signal of a myoma, and it is pedunculated, large in size, and although it is very large in size, but it is not infiltrating the stroma of the uterus or the cervix. And here also there is something else. Look here on the video. I think this case is in the group, on the group also. There is another lesion here in the adnexal area. Here. And this lesion taking homogeneous enhancement also. This lesion, slightly tubal in origin, and here. So don't miss, if you have two pathologies, you have to get these two pathologies. The cystic changes here show also bright signal on T1, so there is hemorrhagic component present. Here, this is the polyp with hemorrhagic component present. Here is the mass taking homogeneous enhancement, and here is the polyp. So the lesion is coming from the endometrium, and it's not cervical. And there is another lesion in the left adnexal region. There is no lymph nodes. Here is the left adnexal mass, and here is the polypoidal intracavitary mass coming from the uterus. And that was the pathology. The left ovarian mass was a benign growth. So, and I thought that from the MR picture, because it is well defined, it takes homogeneous delayed enhancement in the post-contrast study. So it is just a benign growth, and I thought from the picture that it may be fibrothecoma or fibroma. The endometrium, the examination of the endometrium shows a picture of cystic endometrial hyperplasia with hyperplastic endometrial polyp, which show hemorrhage and necrotic changes and no malignancy. So here بقى we will get how to approach a case of endometrial, abnormally thickened endometrium. What are the causes and imaging findings of abnormally thickened endometrium? We must, if we have to get the causes, we must always in the female, you have two age groups, the childbearing age group and the postmenopausal or perimenopausal age group. In the childbearing age group, we have the polyp, hyperplasia, tamoxifen intake, which is very frequent in nowadays due to the tamoxifen intake due to cancer breast. Pregnancy related. If a patient is seen in the childbearing age, you must ask about pregnancy. Incomplete abortion, like incomplete abortion, gestational trophoblastic disease, or ectopic. And then don't miss that endometrial cancer, although rare, can occur in the childbearing age group. While in the post or perimenopausal, we have endometrial cancer, endometrial hyperplasia, endometrial polyp, and exogenous estrogen. Maybe also there may be vaginitis, cervicitis. All this may cause some sort of vaginal bleeding. Endometrial cancer is not the most frequent, but it is the most important. We must exclude endometrial cancer from the start. Polyp. This is the typical appearance of polyp, and I have put just a case of endometrial polyp on the group that the loop was traversing inside. In the endometrial polyp here, this is the sonohysterography, but if you do good transvaginal ultrasound with Doppler, no need to do sonohysterography. This is the polyp, a polypoidal focal lesion present in the endometrium with vascular pedicle sign. This is very typical for endometrial polyp. This is another small endometrial polyp with cystic changes here. And here on MRI, the endometrial polyp has no definite specific findings regarding comparison with endometrial carcinoma. However, the polyp is usually preserving the junctional zone, and on doing dynamic contrast enhanced MRI, the pattern of enhancement of the polyp from the carcinoma can differ. This is the normal MRI of the uterus. This is the normal junctional zone, normal endometrium, and normal endometrium, normal junctional zone. This is the normal differential zonal anatomy of the uterus. This is the normal cervix, inner stromal zone, and outer stromal zone. Endometrial polyps are among the most common pathological lesions of the uterine corpus. They are benign nodular protrusion of the endometrial surface that consist of irregularly distributed of endometrial glands and stroma. It's a very important cause of dysfunctional uterine bleeding, especially in the childbearing age group. Endometrial cancer is the fourth most common malignancy in females and the most common malignancy of the female reproductive tract. The prevalence of endometrial cancer is increasing due to an aging population, combined with the rising level of obesity. Also is a very common risk factor for endometrial cancer. Approximately 75% of cases occur in the postmenopausal women, and mean that we have a good percent in the premenopausal age group, with the median age of diagnosis at 70 years. Adenocarcinomas account for 90% of endometrial neoplasms, while uterine carcinoma are relatively rare and account for only 2 to 6%. Uterine sarcomas are relatively rare, accounting for 2 to 6%, and the remaining histological types include adenocarcinoma with squamous cell carcinoma, squamous cell differentiation, or adenosquamous carcinoma. Endometrial cancer is staged according to the FICO staging that we put the classification above. Endometrial cancer MRI is very important in staging endometrial cancer. It accurately depicts the depth of myometrial invasion, which is the most important morphological prognostic factor, and correlates with the tumor grade. Presence of lymph node metastases are better to be delineated by MRI, especially with the use of diffusion-weighted images. Diffusion-weighted and dynamic contrast enhanced MRI are useful adjuncts to the standard morphological imaging and can improve the overall staging accuracy. Of course, this is a case of, here if there is a mass in the lower uterine segment. This is the normal cervix, and this is the mass, large mass in the lower uterine segment with subsequent hematometra above, and the uterus is markedly enlarged as we see here. Endometrial carcinoma, sagittal T2 weighted MRI image is very important to detect the endometrial cancer, showing nodular, discretely irregular foci of low signal intensity or heterogeneous signal intensity in the endometrial cavity. And here, although it is small in size, however, it is infiltrating the junctional zone below. It's 1BA, 1A. Here, this is the junctional zone, and here the junctional zone is indistinct. This is a small hypo-intense lesion present within the cavity and not infiltrating the junctional zone. Here we have to say that it may be polyp. Of course, we cannot differentiate if it is just a polyp or endometrial cancer. We must to do transvaginal ultrasound and to do DNC, especially if the patient is postmenopausal. This was early carcinoma. This case was early carcinoma, and it's better seen. So when you find hypointense signal in the endometrium, usually correlate with the clinical data of the patient, and DNC is better to do. This is stage 2. Here, the cervical stroma, note here, the cervical stroma is infiltrated. There is a large mass lesion distending the uterine cavity, or if one says thickened endometrium, no problem, but it's a mass. It is a mass distending the uterine cavity, and here the mass is infiltrating the stroma of the cervix, so it is stage 2. And here also there is infiltration. Note here in the dynamic contrast, you can see the infiltration of the junctional zone and the infiltration of the myometra. What about this case? Many of you, when I put cases like this in the exam, they say thickened endometrium. No, dear all, this is not thickened endometrium. Always look on the T1. On T1, it is hypo-intense, it's fluid. This is fluid and not endometrium. The endometrium is similar to the myometrium on T1. Often this post-contrast, but I think on T1 you can see that you can differentiate if this is fluid or this is thickened endometrium. So the bright signal on T2, not only that, we have here, there is a fluid level. Here there is a fluid level seen. Fluid level here, because the patient is lying on her back, so this is a fluid level. So this is fluid distending the uterine cavity and not endometrial thickness. And this is the case that we have not answered yet. The last case I put on the group. So this is the fluid nature. Maybe you find it's bright on T1, so it is blood. If it is low in T1, so it is fluid. We termed hydrometra. Hydrometra, why? This H is not young. If she's young female with primary amenorrhea, we will jump to the congenital uterine anomalies with obstructed nature. But this patient was 50 years old. What is the cause? Who can pick the cause here? This is not a normal cervix. Look, this is not a normal cervix. This is a small cervix with not the cervical canal is not delineated. And this case was cervical carcinoma with post-radiotherapy, and subsequently there is cervical stenosis with hydrometra. Look here. This is the cervix. This is not normal cervix. This is small cervix with indistinct endocervical canal. So this is hydrometra due to cervical stenosis post-radiation. Thank you. I think it will be informative. Another cases will be put inshallah. If you have any comment, please feed me back. Thank you all.